Before anesthesia, before surgery, before even stepping into the operation theater, there's a step that can make all the difference: the preoperative assessment. This is where we meet the patient not just as a name on the OT list, but as a living, breathing story, with their comorbidities, medications, and risks. The purpose? To understand the patient fully, reduce surprises, and plan a safe anesthetic course tailored to them. It begins with a thorough history. We ask about past illnesses, surgeries, allergies, and current medications. We screen for systemic diseases, especially those affecting the heart, lungs, liver, kidneys, and brain. We inquire about exercise tolerance, past anesthetic experiences, bleeding tendencies, and fasting status. Next, we perform a focused physical examination: airway evaluation, vital signs, respiratory status, cardiovascular system, and a general exam to look for clues. These steps may seem routine, but they are crucial. Now comes the part where we categorize risk using a universally accepted scale, the ASA Physical Status classification. This system, devised by the American Society of Anesthesiologists, helps standardize how we communicate patient risk. ASA 1 is a completely healthy patient. No systemic disease, non-smoker, normal BMI, no comorbidities. ASA 2 is someone with mild systemic illness, like a well-controlled diabetic or hypertensive. ASA 3 is a patient with a significant systemic disease, say a patient with stable angina or poorly controlled asthma. ASA 4 represents a patient with severe disease that is a constant threat to life, for example, unstable angina, severe valvular disease, or decompensated heart failure. ASA 5 is a moribund patient, someone not expected to survive without the operation, like a ruptured abdominal aortic aneurysm. ASA 6 is a brain-dead patient being taken for organ donation. If the surgery is an emergency, we simply add an E, like ASA 2E for an appendectomy in a hypertensive patient. But classification alone is not enough. We must also evaluate and optimize risk. Risk stratification involves considering the surgery itself. Is it low risk, like a hernia repair, or high risk, like major abdominal or thoracic surgery? Then we match that with the patient's physiological reserve. This determines how well the patient can handle surgical stress and anesthesia. Optimization is where we step in proactively. We may need to control high blood pressure, manage blood sugars, adjust medications, order further tests, or get specialist clearances. In some cases, we delay elective surgeries until the patient is better prepared. For example, a diabetic with high sugars might need tighter control before surgery. A COPD patient may benefit from preoperative bronchodilators or chest physiotherapy. A cardiac patient may need an echocardiogram or stress test. Each step reduces perioperative risk. Remember, the safest anesthesia is the one that starts before the OT.